Hello, my name is Elizabeth Eslich. I am a radiologist assistant in Pittsburgh, Pennsylvania. I have been practicing as a radiologist assistant for approximately 16 years. I am a radiologist assistant chapter delegate through the ASRT. Today, I want to thank you for inviting me to give you a lecture. At the 2023 ASRT House of Delegates meeting, a lot of students stated they were not familiar with the radiologist assistant. As a result, the RA chapter is working on educating as many students and technologists as possible about radiologist assistants. So, today I'm going to talk about advancing your career as an RT, specifically about becoming an RA. We will discuss what a radiologist assistant is, how to become a radiologist assistant, and what are the expectations after graduation. When we are done with this lecture, I hope you will have an increased awareness of the radiologist assistant profession as a whole, a better understanding of the role of the radiologist assistant in the imaging department. You understand the educational pathway, educational program options, salary, and job expectations. I hope you gain an overview of legislative initiatives related to the radiologist assistant profession, both federally and on the state level. I hope I have made you feel empowered to get involved. Now that you are a radiologic technologist, what else can you do? This slide lists the multiple avenues for advancement now that you are an RT. The opportunities are endless. You could advance to CT, MRI, mammography, bone densitometry, interventional radiology, or cath lab. You could transition to management, education, sales, or software or PACS. You can continue your education to ultrasound, nuclear medicine advanced associate, radiation therapy, advanced radiation therapy associate, dosimetry, or, of course, the radiologist assistant. Let's take a look at the history of the radiologist assistant profession. The idea of educating radiologic technologists to serve as physician extenders in radiology is not new. You may know that advanced level radiologic technologists have been working in England for more than 30 years. Some of their titles include diagnostic radiographer or therapeutic radiographer, advanced radiographer, or consultant radiographer. While the job descriptions for these individuals in the UK vary greatly, the concept of the RA in the US is fairly standardized. In the early 1970s, radiology physician assistants, or essentially super techs, were trained on the job and did not have a formal certification process. In 1993, the Department of Defense approached Weber State University in Utah to address the radiologist shortage. The initial aim was to keep radiology services in radiology. However, shortly after the discussions and implementation of a curriculum and certification exam, the Department of Defense abandoned this idea of the radiology physician assistant. But in 1996, Weber State pursued and established the radiology practitioner assistant, RPA, not radiology physician assistant as most think. Then in 1999-2000, the first RPAs graduated and entered the workforce. RPAs are certified by the CBRPA, which is the Certifying Board of Radiology Practitioner Assistants, which was established out of Weber State University. Around 2002, a task force was created with members from the American College of Radiology, the ASRT, and the ARRT. These organizations came together to develop the Registered Radiologist Assistant model. In 2003, the ACR and ASRT released a joint statement recognizing the radiologist assistant as an advanced career path for radiographers. Loma Linda University took its first class of students in 2003, and in 2005, the first graduating class of RRAs entered the workforce. So for a while now, both RPAs and RRAs have been entering the workforce, at least around 615 approximately RAs, both RPAs and RRAs around the country at last count. What is a radiologist assistant? A radiologist assistant is an advanced level radiologic technologist who enhances patient care by extending the capacity of the radiologist in the diagnostic imaging environment. What exactly does that mean? We will discuss specific details about the work that the radiologist assistants do in more depth a little later in the presentation. But other terms you may hear when referencing radiologist assistants may include physician extender, advanced practice provider, APP, non-physician provider, NPP, or mid-level provider. One key point is that radiologist assistants only work under the supervision of a radiologist as part of the radiologist-led team. As part of our training and education, the radiologist assistant completes an advanced academic program encompassing a nationally recognized radiologist assistant curriculum alongside a radiologist-directed clinical preceptorship. For the purposes of this discussion, the radiologist assistant career encompasses both Registered Radiologist Assistant, which is certified by the ARRT, Radiology Practitioner Assistant, which are certified by the CBRPA. While there are two different credentials for radiologist assistants, the educational pathway for both are very similar. Think of it in terms of the two different credentials available to physicians, the medical doctor, MD, and the doctor of osteopathic medicine, DO. Both professions have a lot of overlap, and they essentially perform the same function in medicine. With radiologist supervision, the radiologist assistant performs patient assessment, patient management, fluoroscopy, and other radiology procedures. While the radiologist assistant makes initial observations of studies that they perform only to the supervising radiologist, it should be noted that the radiologist assistants do not provide an official interpretation or a final written report, as defined by the American College of Radiology Standard for Communication and Diagnostic Radiology. Now, let's talk about RA programs. All of the radiologist assistant programs are done mainly online with campus visits once or twice per semester. Loma Linda University in Loma Linda, California. They were the first RA program that opened in 2003. Midwestern State University in Wichita Falls, Texas. First class started in 2004. Quinnipiac University in Hamden, Connecticut. First class started in 2008. The University of North Carolina at Chapel Hill in Chapel Hill, North Carolina. First class started in 2005. Weber State University in Ogden, Utah. Only program that offers RPA and Registered Radiologist Assistant. First students for RPA were in 1996, and they started offering the Registered Radiologist Assistant in 2007. Rutgers University in Newark, New Jersey. First class started in 2005. After graduation, you can apply to take the RPA exam through the CBRPA. Of the original 10 schools that started with RA programs, 4 are currently closed. The University of Arkansas, Medical Sciences in Little Rock, Arkansas. Ohio State University in Columbus, Ohio. Wayne State University in Detroit, Michigan. Virginia Commonwealth University in Richmond, Virginia. As you can see, we have lost 4 of our 10 programs. This is largely due to the Centers for Medicare and Medicaid not allowing radiologists to bill for the non-technical services provided by radiologist assistants. We will talk more about federal recognition later. A list of current programs with contact information can be found on the ARRT website under Radiologist Assistant Educational Programs. So, how do you become a radiologist assistant? To apply to any RA program, you must be a registered technologist in good standing with the ARRT. All of the programs are master's degree level programs, so you must have a bachelor's degree to apply. You need basic CPR certification. Currently, all programs require 2 years of experience. University of North Carolina is changing for the 24-25 admissions, except for Quinnipiac is 2,000 hours of experience, which is about 1 year as a radiographer. For students enrolling in programs on or after January 1st, 2025, a minimum of 2 years experience will be required prior to starting the RA program. This is a new ARRT requirement. Some programs have GPA requirements. Loma Linda requires a 2.5 GPA or higher. Rutgers, Midwestern State, and the University of North Carolina require 3.0 GPAs or higher. Quinnipiac and Weber State don't have any GPA requirements. Some programs require your CV or an essay or both. Lastly, What is a preceptor agreement? In addition to the educational journey, the radiologist assistant student participates in a radiologist-supervised clinical preceptorship and learns how to perform radiologic procedures and activities that appear in the Registered Radiologist Assistant entry-level clinical activities. You must maintain a record of clinical experiences and evaluations in the form of a clinical portfolio, which consists of 4 components: the clinical experience documentation and competence assessments, professional activities and accomplishments, case studies, and summative evaluation rating scales. Since these programs are done online, you will need to find a radiology group and hospital to agree to act as your clinical site. This means the radiologist agreed to teach and supervise you, and the hospital allows you to perform procedures. Some programs want this secured before you apply, and some programs will help you with this after you are accepted, and some programs have set clinical sites. It can be challenging to find a hospital and group willing to train you, and sometimes they may want to train you in exchange for employment after graduation. Some students are even able to get the group to pay for their education in exchange for a post-education employment agreement. In order to apply for certification and take the Registered Radiologist Assistant exam through the ARRT, you must be ARRT certified in radiography, hold a current Advanced Cardiac Life Support certification. Some education programs require getting this before beginning the program, and others allow you to get this during the program. Must have 1 to 2 years experience in radiography. Those graduating prior to January 1st, 2025 require only 1 year experience prior to enrolling in the program. Those graduating after January 1st, 2025 will require 2 years of clinical experience prior to enrolling in the program. Successful completion of a radiologist assistant educational program that is recognized by the ARRT. This must be completed prior to sitting for the examination. You must meet the didactic and clinical requirements for certification. These will be discussed in the next few slides. With completion of any of the ARRT approved Registered Radiologist Assistant programs, you will earn a master's degree, which is required to take the exam. I am certainly not going to read everything on this slide, but you can see the extensive list of the areas covered in the ASRT Radiologist Assistant curriculum. This information will be taught over 2 years and gives you the fundamental knowledge required to act as a radiologist assistant. Performing procedures and being a leader in patient care requires a rigorous academic program. The topics covered within the ASRT RA curriculum fully address the items listed in the ARRT Registered Radiologist Assistant examination content specifications. Each candidate must submit a total of 18 clinical competencies, 15 from the mandatory procedures and 3 from the elective. You must have 1 elective from the GU category, 1 from the invasive vascular category, and 1 from the invasive non-vascular category. Mandatory clinical exams can be found in each box. Mandatory means you must have the minimum number of each exam. The number after the procedure is the minimum number required. For example, esophageal study, 20, means you need a minimum of 20 esophograms. Some students have to set up another clinical site in order to get the required number. For example, barium enemas can be very difficult to get because of the alternative options like CT colonography and colonoscopy. Now let's take a minute to go over the mandatory procedures. I imagine each of you are familiar with the exams done in fluoroscopy. You need 20 esophograms, 10 modified or speech swallow studies, 15 upper GIs, 10 small bowel studies, 10 enemas of any type. They could be single or double contrast, and they could use barium or water-soluble contrast. 10 NG or OG tube placements, 10 NG, OG, or G-tube injections. These are done to check for accurate placement of the tube. 10 postoperative GIs or esophograms to check for leak or obstruction. 10 cystograms, voiding cystograms, or voiding cystourethrograms. 20 arthrograms. These can be diagnostic, which means the post-injection imaging is done in fluoro, or an injection for CT or MRI, which means the contrast is injected in fluoroscopy, then the patient is sent to CT or MRI for additional imaging. You need a minimum of 5 hip and 5 shoulder. 10 lumbar punctures, which are done to obtain spinal fluid, 5 myelograms performing the post-contrast imaging, 15 thoracentesis, which is a procedure usually done under ultrasound guidance to drain pleural fluid from around the lung, 20 paracentesis, another procedure done under ultrasound guidance that drains fluid from the abdominal cavity, 10 PICC line placements. A PICC line is a peripherally inserted central catheter, or a long-term IV in the upper arm. This is usually done in interventional radiology using ultrasound to find the vein and fluoroscopy to place the catheter. Now let's go over the elective exams. Some of these require as little as 5 and some as many as 20. It varies by procedure. I'm going to go over each of these procedures briefly because a lot of you may not be familiar with them. These procedures are not performed as commonly, which is why they are elective procedures. First, T-tube cholangiogram. This is an injection of an indwelling T-tube with contrast to evaluate for biliary patency and filling defects. Chest fluoroscopy, also known as a sniff test. This is when you have the patient sniff to look for paradoxical movement of the diaphragm. Nephrostogram. Injection of a nephrostomy catheter to check placement or patency of the collecting system. Urethrogram. Uses contrast to visualize the urethra. A lupogram. This is done after a urinary diversion procedure is performed. A urinary diversion procedure uses a loop of bowel to act as a ureter. So for a lupogram, you put a catheter into the ostomy on the skin and then inject contrast to evaluate patency and anatomy. Hysterosalpingogram, or HSG, done to evaluate tubal patency for pregnancy. This can be done with the gynecologist doing the procedure and the radiologist assistant taking the images, which is known as imaging only, or the radiologist assistant doing the procedure and taking the images, which would be imaging and procedure. Joint injection or aspiration. Joint injections are steroid injections into the joint for pain relief. Joint aspirations are done to rule out infections of the joint. Bursa injection or aspiration. This is almost the same as a joint injection aspiration, but of the bursa. Steroid injection for pain and aspirations for possible infection. Chest tube for pneumothorax. This is when you get air around the lung spontaneously or from a procedure like a thoracentesis or lung biopsy. You would place a tube in the pleural space to remove the air from around the lung. Abscess, fistula, or sinus tract study. An injection of contrast through an indwelling catheter to look for a fistula. Sentinel node localization. Injection of radioactive material or dye to see if breast cancer has spread. Percutaneous drainage, with or without a catheter. Drainage of a fluid collection and leaving a catheter or not. Change of percutaneous drainage tube is when you insert a wire into an indwelling catheter and place a new catheter over the wire. Biopsies. Superficial lymph node, superficial soft tissue mass, thyroid biopsies are all done to look for cancer. Non-targeted or random liver biopsies are done to evaluate patients with abnormal liver function test. Insertion of non-tunneled central venous catheters. This would be temporary dialysis catheters for dialysis or central lines that act as IVs. Central venous catheter or port injection. This is an injection of contrast through a dialysis catheter or port done for poor function of the catheter to see if you can identify the cause. Tunneled venous catheter removal would be a port or tunneled dialysis catheter removal when they no longer need it. Extremity venography. This is injection of contrast into the extremity veins, usually done for vessel mapping. Previously, it was done for DVT, but ultrasound is the new imaging modality of choice for DVT. CT or MR processing. Reformatting of CT or MR images. How does the radiologist assistant compare to physician assistants and nurse practitioners? There was an article published in 2012 in the American College of Radiology Journal, comparing the educational program requirements for physician assistants, nurse practitioners, and radiologist assistants. The comparison chart shows that the physician assistants and nurse practitioners don't receive any radiology-specific training, and the radiologist assistants do. Radiologist assistants don't have prescriptive authority or receive education on health promotion and disease prevention. As this chart shows, the three extenders have very similar curriculum except for the radiology education and prescriptive authority. A benefit of radiologist assistants over other mid-level providers like nurse practitioners and physician assistants is they have the background and training in radiation protection, radiographic anatomy and pathology, and specific radiology procedures. Not only is this included in the RA curriculum, but all radiologist assistants were technologists first. I know I don't have to tell any of you how rigorous the RT curriculum is. This extensive training results in less on-the-job training required for radiologist assistants when compared to other mid-level providers. When a radiology practice hires a radiologist assistant, after credentialing, the radiologist assistant needs little training to become familiar with equipment, electronic medical record system, and department protocols. Typically minimal, if any, training is needed for the procedures performed. Most radiologist assistants are done training within a few weeks. When a nurse practitioner or physician assistant is hired with no radiology background, it takes approximately 6 to 12 months for them to be done with training. They are usually not familiar with radiology at all. What is the benefit of hiring a radiologist assistant? Radiologist assistants have been proven to increase department and practice efficiency and patient access to radiology by improving workflow. The radiologist assistant can do this by relieving the workload for the radiologist. The radiologist assistants can do the minor procedures while the radiologists do the more invasive procedures and read exams. This creates time for additional procedures to be done each day. This results in sooner appointments and less time in the hospital getting the procedure done. The ability to fit more minor procedures in each day allows for earlier patient discharges. An example of this would be a patient has a 11 a.m. appointment for a thyroid biopsy. At 10 a.m., the interventional radiologist gets a call about a patient with a GI bleed. This patient needs care emergently. The interventional radiologist starts the GI bleed at 10:30 and doesn't finish until 12:30. These cases can take more time to find the bleed and embolize it. If you have an extender, the thyroid biopsy can be done while the radiologist is taking care of an emergent patient rather than waiting for the radiologist to finish his case. Radiologist assistants allow for continuity of care, which may be hard to achieve without them. Patients that come to the department often for repeated procedures, like drainages, for example, love continuity of care. They form a relationship with the technologist and nurses. They can also form a relationship with the provider. It can be difficult to do this when your provider changes frequently. If you work at an academic institution, the radiology residents are always rotating through different areas. A lot of radiology departments have rotating physicians with other hospitals. The radiologist assistant has more time to dedicate to the patient through counseling, education, and answering questions. The time we spend with the patient allows the radiologist to continue interpreting complex or urgent exams more efficiently. Extenders are usually more consistent on site than the providers, allowing for continuity of care. This makes the patient feel that they have received personalized care. Anytime a patient is interacting with a provider, it is perceived by the patient as value added to their procedure. When patients feel they have received quality care, it shows. I will say that one of my favorite parts of my job is having a patient request me or schedule their repeat exam on my days. These instances show me that I have chosen the right career. This isn't different than a patient requesting a specific provider at their doctor's office. The patients form a relationship with their provider and they like to see the same provider on each visit. When discussing with radiologists and asking them what they think a benefit of having a radiologist assistant is, some radiologists mention decision fatigue. I know we already talked about the benefits of practice efficiency, But another way to look at this is what the radiologists call decision fatigue. By reducing the number of times the radiologist gets asked to answer questions about protocols, the radiologist assistant can reduce decision fatigue as well as the number of interruptions while interpreting. These interruptions can result in more errors in reporting and delay patient care. For example, an order is placed for a lung biopsy. The radiologist assistant will work up the order. The patient may have an outside chest CT with no images in the system. The radiologist assistant can facilitate receiving the CT images prior to asking the radiologist to approve the biopsy. This leads to less questions for the radiologist. What does the radiologist assistant do during each phase of the procedure? Everything the radiologist assistant does is done as part of the radiologist-led team, which means they are always working under the supervision of the radiologist. In the pre-procedure phase, the radiologist assistant can do history and physicals, which are required within 7 days of invasive procedures. As you can imagine, this is a huge time saver for the radiologist. The radiologist assistant can evaluate each procedure using the ACR appropriateness criteria. If the procedure isn't indicated, the radiologist assistant can speak with the referring provider to coordinate the ordering of the most appropriate exam. The radiologist assistant can participate in informed consent. This can vary with credentialing and by the state. For example, in the state of Pennsylvania, extenders can obtain informed consent for any procedure they are performing. If the radiologist is performing, then the RA can participate in informed consent, but the radiologist must get the official consent. The radiologist assistant can evaluate all patient medications prior to the procedure with medication holds to determine if the patient has adhered to institutional policy. They can also evaluate all lab values prior to the procedure. The radiologist assistant discusses normal and abnormal lab values and an appropriate action plan with the radiologist. The radiologist assistant can then communicate the protocols and action plan to the referring team or provider. In the intra-procedure phase, the radiologist assistant can perform many procedures as we discussed on the previous slides. They can administer and document medications given. Radiologist assistants don't order or prescribe the medications. They are ordered by the radiologist or per facility protocol. They can assess and monitor patients during procedures done with and without sedation. In the post-procedure phase, the radiologist assistant can make sure the appropriate images were obtained and proper protocols were used. The radiologist assistant can provide their initial observations on exam they perform to the radiologist. Radiologist assistants can communicate the radiologist report or critical findings to other healthcare providers. Radiologist assistants can organize follow-up appointments and imaging. RAs can also do rounding on patients post-procedure to manage strains, evaluate symptom relief, and etc. Radiologist assistants can participate in a variety of quality improvement activities for the radiologist. Let's elaborate a little more on providing initial observations. Radiologist assistants do not provide an official interpretation. They make initial observations of diagnostic images and communicate their observations only to a radiologist, and then the official interpretations or final written report is provided by the supervising radiologist. This is defined by the ACR. The radiologist assistant cannot work independently. Radiologist assistants always work under the supervision of a radiologist. Radiologist assistants are a supplement to the radiologist, not a substitute. Radiologist assistants are frequently the first line for procedure request. As soon as the order comes in, the radiologist assistant can work up the request. First, what is the request? This seems like it should be straightforward, but not always. With the electronic ordering systems, the physicians cannot always find the correct order and may order something different and type it in the comments. So first, we'll figure out what exactly the request is. Next, let's look at if the procedure is indicated. Will this fix a problem or answer a question? Is this correct side ordered? If the patient has right hip pain and the order is for left hip steroid injection, then the order is likely incorrect and needs verified. Imaging review is done to decide if the procedure is possible and the best modality to use. And patient positioning for the procedure. Sometimes orders come through and the patient doesn't have prior imaging at our institution. Imaging is always needed when looking at a biopsy or drainage request. Then we look at, is the procedure possible? Is the lung nodule accessible? Can we get there safely? What is the lung capacity in case the patient gets a pneumothorax? Which modality would be best and why? In the example of a lung nodule, CT would likely be the modality of choice because it is difficult to visualize the lung nodule with other modalities. You can also see vessels to avoid with CT. Next, we'll evaluate the patient's lab work. Do we have a routine pre-procedure labs and are they within normal limits? Understanding what the labs mean and why the labs could contraindicate the procedure is important. Does the patient have any pertinent allergies to the procedure? Specifically, will the procedure require contrast and does the patient have a contrast allergy? Other allergies are usually simple to work around. Is the patient on any blood thinners that would contraindicate the procedure? Lastly, can the patient sign consent? If not, who signs for them and can you get in contact with them? The average day of the radiologist assistant will vary for each and every radiologist assistant. No two RA jobs are the same. There are some RAs who will cover all areas of the department daily, some who just work in one area like IR or fluoro daily. Some rotate every other day or weekly. For me, my average day involves all modalities: CT, IR, fluoroscopy, and ultrasound. I work Monday through Friday from 7:30 to 4. No weekends, no holidays, no call. My first patient is scheduled for 8 a.m. I start at 7:30 and start evaluating all of the cases that are on the list for the day. I go over the schedule and add-on cases. I evaluate each request, check prior imaging, medications, labs, and etc. Basically, everything we just discussed on the previous slide is the algorithm that I go through for each case. After I have worked up each case, I go over every case with my attending radiologist and make a plan for each case. I communicate the plan to the radiology team and the patient's care team. In IR, I place PICCs, drainage catheters, ports, and dialysis catheters. In ultrasound, I do biopsies like thyroids, livers, and lymph nodes, and fluid drainages like paracentesis and thoracentesis. In fluoro, I do all of the GI procedures, joint injections and aspirations, lumbar punctures, myelograms, and hysterosalpingograms. In CT, I do the bone marrow biopsies, drainages, and SI joint injections. I continually work up add-on cases as they come up throughout the day. I'm constantly talking with my interventional radiologist about the plan for each case. I provide initial observations to the radiologist of each case that I do. I also coordinate all of the pre- and post-procedure testing and follow-up for our IR clinic. I see any inpatients that need follow-up. I review any biopsies or complex cases with my radiologist prior to scheduling to determine the imaging modality and coordinate scheduling. I obtain consent for my procedures and provide patient education. Now that I have explained all of that to you, I'm sure you can see how radiologist assistants can make the department more efficient. Now that you have applied to a radiologist assistant program, completed the program with all of the mandatory and elective procedures, now what? Now you need to take the exam and get a job. But how do you do that? First, you need to apply to take the ARRT, Registered Radiologist Assistant exam. This is similar to the RT exam. You apply on the ARRT website. The exam is offered twice per year, the second Thursday of January and July. You have to apply approximately 8 weeks prior to the exam date. You will take the exam at Pearson VUE. Now you need to find a job. At the time of making this presentation, there's approximately 30 open jobs. This figure does change, but I would say in the past 2 years, there has been a steady 20 open jobs consistently. For the small numbers of radiologist assistants, about 600, that is quite a few jobs. However, in order to get a job, there is a possibility you may need to relocate. If relocating is something you wouldn't be able to do, you should look into job opportunities around you and talk with the radiology programs to see what options you might have before you start the program. Radiologist assistants are still a new concept, and I wouldn't be giving you this presentation if everyone knew what they were. Radiology practices are still discovering them and hiring their first ones. Does it matter if your state has licensure? If your state doesn't have licensure to recognize the radiologist assistant, it doesn't mean you can't work in that state. Some radiologist assistants can work under the Physician Delegation Act and some recognition from the State Department of Health allowing them to work. Once MARCA passes, radiologist assistants in states without licensure may have difficulty working. We will talk more about that later. What is the salary expectation for a radiologist assistant? The average salary is $132,000 per year. The average salary for a physician assistant in radiology is $125,000 a year, and the average salary for a nurse practitioner is $126,000 per year. As of 2023, there are about 615 radiology extenders working in the U.S. This map breaks it down by state. You can see Texas has 54, and other high numbers can be found in Florida, Pennsylvania, New York, and California. Then we have states with 0, like Delaware, Alaska, and Hawaii. These numbers grow every year. There are a few myths that seem to float around about the radiologist assistant. Let's bust them. 1. There are no jobs. Absolutely false. As we talked about earlier, there are approximately 30 posted jobs right now, and it seems at any given time there are at least 20 jobs available. Next, radiologist assistants will replace radiologists. False. Radiologist assistants work under the supervision of a radiologist and are meant to supplement the radiologist. Radiologist assistants need to prescribe. False. Since radiologist assistants work under the supervision of a radiologist, there is no need to prescribe. The radiologist can prescribe any meds that are needed. Radiologist assistants don't have pharmacology or patient assessment education and training. False. The radiologist assistant curriculum includes both patient assessment and pharmacology. Last, radiologist assistants need to have state licensure to work in that state. False. Currently, radiologist assistants can work in states with and without state licensure. Working in states without licensure may look differently for each state, but it is possible. 33 states currently have radiologist assistant licensure, or language pertaining to the practice of RAs. Pennsylvania and Georgia are the only 2 states on this list that don't have state licensure recognizing the radiologist assistant. But they have a letter from the state that says that radiologist assistants can practice as credentialed by the hospital. It is essential for states to obtain licensure or language regarding the radiologist assistant. Because the federal amendment to the Social Security Act will defer to the individual states for recognition and to set supervision levels for the radiologist assistant practice. What are the hurdles for the radiologist assistant profession? MARCA, which stands for Medicare Access to Radiology Care Act, is the biggest hurdle to the RA profession. Without MARCA, reimbursement for procedures that RAs perform is a problem. As a result, radiologist assistants are losing their jobs, and some radiology practices are opting to hire physician assistants and nurse practitioners to replace us. PAs and NPs can bill for procedures performed in radiology. Additionally, as we discussed earlier, some of the RA programs are permanently closed. The MARCA legislation has yet to be introduced into the 118th congressional session. It has been introduced in past congressional sessions, but has yet to be passed. This is not uncommon. When bills are introduced, they should be bipartisan in nature. The ASRT and ARRT are working towards the passage of MARCA. They have lobbyists that help with this bill and other important bills in radiology. Let's look at MARCA a little closer to explain why it's important. Before we discuss the details of MARCA, I want to explain supervision levels for procedures which are performed in radiology. First of all, when it comes to reimbursement by the Centers for Medicare and Medicaid, also known as CMS, the RA profession isn't currently recognized. Therefore, RAs are recognized as technologists. CMS requires specific supervision levels for technologists to perform exams in order for the professional and technical components to be paid to facilities and radiologists. First, we have general supervision. This means the procedure or service is furnished under the physician's overall direction and control, but the physician's presence is not required during the performance of the procedure. This means that the radiologist is available for consultation by phone, but does not have to be on site. An example of this exam that requires general supervision is a chest X-ray. Direct supervision means the physician must be immediately available to furnish assistance and direction throughout the performance of the procedure. It does not mean that the physician is present in the room when the procedure is performed. This means the physician is available to come to the room if needed, or is on campus. An example of this procedure requiring direct supervision would be a CT chest for PE. Personal supervision means a physician must be present in attendance in the room during the performance of the procedure. Keeping with the chest example, fluoroscopy of the diaphragm procedure requires personal supervision. Again, currently, radiologist assistants are recognized as radiographers and therefore must follow the same supervision levels. This is where MARCA comes in. So what exactly would previous versions of MARCA have accomplished? First, MARCA recognized radiologist assistants as mid-level providers by inserting the RA, which includes the RRA and RPA, into the Social Security Act. This is the same process that was required for recognition of nurse practitioners and physician's assistants in the past. Second, MARCA ensured that services provided by a radiologist assistant are reimbursed, regardless of the setting in which the radiology service is performed, hospital, outpatient center, or other facility. However, this will only apply to RAs who are supervised by a radiologist as part of the radiologist-led patient care team. The third thing MARCA would have accomplished in its prior form was allowing each state to set the desired supervision levels for radiologist assistants. This would allow radiology practices to provide input to legislators regarding how each state would regulate the practice for RAs. Lastly, MARCA allowed for services provided by radiologist assistants to be paid directly to the radiologist. Thus, RAs will not be able to bill independently as other mid-level providers, like nurse practitioners and physician assistants currently do. This caveat will help ensure that RAs do not push for independent practice, as currently being seen throughout the country with other extenders. In addition to payment being provided directly to the radiologist, services would have been paid at a reduced rate of 85%, which is currently the same reimbursement rate for other extenders like physician assistants and nurse practitioners. At one time, we had obtained a score from the Congressional Budget Office, which showed that this rate of reimbursement would be budget neutral to the U.S. deficit. The overall purpose of MARCA, as previously introduced, was to expand access to care for patients during times of radiologist shortage, especially in rural areas of the country where it's harder to recruit physicians or there is limited access to radiology. Again, all of this information is based on previous versions of MARCA. ASRT and ARRT are actively working on legislative initiatives to gain recognition of the RA. One reason, of the many reasons state licensure is so important, is because if MARCA passes as previously introduced, it would have deferred back to the state RA practice guidelines. It should be noted that the ACR has been instrumental in the implementation of the radiologist assistant career. This is so that they could provide input throughout the process. The RA profession is based on the anesthesia assistant that provides anesthetic care under the supervision of a licensed anesthesiologist, as opposed to the certified registered nurse anesthetist, or CRNA, who can practice independently. There is a lack of education about what the radiologist assistant does and how they practice. Also, a lack of education about what the radiologist assistant entails. The purpose of MARCA was to gain recognition of the radiologist assistant to allow for Medicare and Medicaid billing. Some positive news to share is that we have made some strides with the Veterans Affairs system over the past few years. From 2017 to 2019, There were several meetings with representatives in Congress, and we were able to secure the qualifications and standards related to the radiologist assistant. The first step is securing a job description for the radiologist assistant. In early spring of 2021, a job description was developed which incorporated a variety of tasks, including performing procedures, quality management, assisting the radiologist, performing and documenting physical exams, protocoling, discharge instructions, patient education, and educational training for technical staff. These are only a few of the tasks that were included in the VA job description. Now that the job description has been secured, RAs are able to apply for positions within the VA system. Now, what can you do? The first thing you can do is join your professional society. There really is a professional society for everyone. You can see the many options on the screen. This is just the tip of the iceberg. By joining and getting involved in your state affiliate society, you will be a member of the technologists within your state and will be a part of the group that will help enact change in your state. This is where you will see changes that will directly affect your practice. Not only will joining your state and national societies allow you to support advocacy efforts, it provides you with networking opportunities that help you stay in touch with other medical imaging professionals in your area. Additionally, your state and national societies provide opportunities for continuing education, just like this one. I can't imagine where I would be without the networking opportunities I have had through my service to ASRT and attendance at educational conferences. I have reached out to my fellow RAs to consult on cases or imaging findings from across the country more times than I can count. These connections are vitally important when we are discussing potential changes to our practice or new exams I haven't done before. I have also made some of my best friends through volunteering. You can also volunteer with the ARRT. The future of our profession depends completely on our actions as medical imaging professionals. What else can you do? You can spread the word by talking with radiologists, colleagues, patients, and other healthcare providers. If we tell one person, they may tell another person, or maybe even more than one other person. This is how we can spread the word. Radiologists need to know why RAs are the best choice for radiology. It is imperative that all RTs understand the RA profession and how it can impact their practice and career advancement opportunities. Patients also need to understand what RAs are and their role in the radiology department. More importantly, we need to explain not only the RA profession to other healthcare providers, but all aspects of medical imaging and radiation therapy. We need other healthcare providers to understand that we are professionals and why we are the best choice to provide radiology services to our patients, family members, and friends. Lastly, you can visit the ASRT Advocacy Center and send letters to your legislators asking them to support MARCA, if and when it is reintroduced. You can also call their DC office or set up meetings in district offices with representatives or their staff to further explain MARCA and what MARCA is and how its passage can positively impact healthcare for our patients. If you get a call to action email about any radiology issue from the ASRT, please do it. It only takes a few minutes. If you want additional advice or guidance on advocacy efforts such as meeting with staff or congressional leaders, feel free to reach out to your state affiliate leaders, myself, or the ASRT. Through the ASRT Advocacy Center site, you can access all ASRT advocacy initiatives. When there is a bill to take action on, you will find a link in this section of the website. You can also access documents and resources related to the RA and MARCA legislation. On the Action Center page, you can see further information about federal bills under the Federal Issues homepage, or issues affecting your state by going to the State Issues homepage and choosing your state. This is where you will find any pertinent state legislative efforts affecting technologists in your area. You can also review the current state regulations or join your affiliate here. Now we're going to wrap things up. I would like to thank you again for having me speak to you today. I hope you now have a better understanding of what a radiologist assistant is, what they do, how to become one, and that there are plenty of jobs available. You should now recognize that there are some hurdles to being a radiologist assistant, but we hope to have them resolved in the future. I hope you all leave here and decide to volunteer with your state affiliate, ASRT, or other organization to help influence the future of radiology. Now we have some time for questions. If you don't have a question now, you can always reach out to the RRA community on the ASRT communities page. You can email an RRA chapter delegate, which you can find an email through the ASRT communities, or you can look on the RA page on Facebook. The Registered Radiologist Assistant chapter would be happy to provide this lecture at any meeting. Thank you very much for your time.
Hi, everyone. It's Elizabeth. Thanks for listening in. I see a question in the chat here. As AI takes on more radiologist roles, would these assistant duties fall on them rather than training and hiring assistants? They could take on more patient care duties. I don't think AI is going to change the roles of the radiologist assistant. I think the radiologist roles may evolve a little bit with AI help with dictation software and PACS, but I don't think the procedures that we do can't be done by AI, so I don't think that'll impact us if that answers your question. Are there any other questions?
I see a hand raised for Carl.
Go ahead, Carl.
Okay, yeah. So my question was, say you have a radiologic technologist that has his Bachelor of Science degree and chooses to go into a physician assistant program. I don't see the advantages as clear as what you pointed out. For them, I feel like there would be a lot more to gain for that individual becoming a physician assistant and still having a specialty in radiology. How do you feel about that? Or can you expand on or clear the that thought for me? Because I just don't see there's so many advantages of the physician assistant versus a radiology assistant in my mind. Salary's one, what you're spending on the education is equivalent, and you have a lot more responsibilities, you're paid more. So yeah, I just don't see where the radiology assistant is more advantageous than going through a physician assistant program.
I agree with you, Carl. I mean, to answer your question, I think the education, it's an additional 2 years either way. Prices, varies, but about the same depending on the program you choose. Salary, I think on the salary survey there, you saw they're pretty equal. Sometimes it depends where you are. The RAs will make a little bit more because of their background and expertise in radiology, and the PAs won't. I will say a PA with an RT is a little bit different, and they're kind of something special that a lot of people don't find or have, but I do think that they end up being that kind of cream of the crop for an extender in radiology. But the disadvantage is they're not getting any radiology training in their PA program. So for the RA, they get their whole 2 years in radiology, learning fluoro, learning, IR cases, ultrasound cases. Granted, an X-ray tech already has that background of at least fluoro, but I can speak from my experience in just training a PA, and I've never trained a PA with an RT, but I've spent quite a lot of time with them just teaching them, the basics of imaging. So I think if you could take that away, they definitely come in with a big advantage.
Yeah, I'm a radiation therapist, and they're coming up with the advanced practice radiation therapist, and I just continue to see this as a watering down of our profession, which we've made so many strides, and we still have some gaps there about all this. Like you said, there's not all states license, as you pointed out. And, to me, you know, um, when I first heard of radiology assistant, I just assumed they were equivalent to a physician assistant, which is not the case. And I don't know where you got the salary um, information. I'd like to see that, because, just based on the the responsibilities of a physician assistant versus RA. The RAs aren't able to do a lot of the procedures and stuff that a physician assistant would be. So the fact that a physician's assistant wouldn't be more, um, for valuable to a department versus an RA who has a lot of limitations, I'm just not seeing it. And the same thing when they're talking about the advanced practice. I mean, they're talking about this education, and it's in other countries, where we don't have the healthcare reimbursement system like we do. They are considered providers, and it's I just feel like that we should be pushing for that to try to get that professional recognition that we've been striving for so long.
Yeah, I agree. I can tell you the references for the salary surveys are in the PowerPoint presentation. If
Huh?
you don't have access to it, I can definitely email those to you. And also, just for reference, I work with about 15 to 20 extenders. I work in a 10 hospital system, and I would say there's about 6 RAs and, maybe 10, 11 PAs and one nurse practitioner, and I know the RAs are making the same as the PAs.
I just that's news to me. Because they do, there's just because of all the I mean the physician assistants, they have, what is it, the EPN numbers. RAs don't. I mean, the physician assistants can come in, be trained, and do exactly what radiologists are doing, and RAs cannot.
What can the PAs do that the RAs can't?
Um, there's a lot when it comes to the clinical part of what they can and can't do. Um,
I
I
guess
mean,
I'm
as
not sure
far
about
as,
that.
like physician assistants, they can diagnose. An RA can't diagnose.
Well, we don't
They
need to
can't.
diagnose in radiology, I guess.
Excuse me.
In radiology, we don't diagnose.
Who,
The
who
the
doesn't
procedures
diagnose?
we perform are just performing procedures. We're not, you know what I mean?
For RAs.
We're not seeing a patient and diagnosing a patient with a disease. That's not what radiology does. So yeah, on a family practice or in the ER, that kind of level, absolutely different, but that's not how an RA is meant to function.
An RA, but not the PAs.
Right. The RAs only work in radiology. They can only work under the supervision of a radiologist. So we could never go work in the ER, internal medicine, surgery. We can never do any of that. So yeah, they do have a hand on that aspect, but that's not what a radiologist assistant is for. They're for the procedures in the department in radiology. Danielle, I see your
Yeah.
question here about more RA jobs. I think there's already 30 open RA jobs any given time, if not more. And I think the more jobs keep coming up, there's not enough RAs to fill them. Any other questions?
I have a question. So that legislation that you brought up that I guess may eventually get passed, is there any kind of like update in terms of like if licensure will be required essentially across all states, or like is there anything you can add to that?
So Marca is a process. Did not get passed last session. It has not been reintroduced this session. I think they were close to introducing it, and as you know, our government has not been really functioning lately. So I think as soon as hopefully the government gets up and running again, we will be reintroducing the legislation this year. But I mean, also think it's important to remember it took the PAs, I think it's 17 years to get recognized and their legislation passed. We're just hitting that point with the RA. So it just takes time and you have to just be persistent. I'm hopeful it'll happen soon. Any other questions?
Okay, if there are no other questions, we'll go ahead and wrap up the meeting. If you do have something to say, I did put Elizabeth's information in the chat. Her email is included. But thank you so much for Elizabeth for sharing your information, and thank you everybody for bearing with us. I know we took a little bit to start, but thank you for joining us tonight, and you're very appreciated, Elizabeth.
Thank you. It was a pleasure.
Thank you. Have a good night, everybody.
Thank you.